Oh, thanks, Caitlin Lewis, for turning off the chimes. Now I can no longer see the slides. Can everybody see the slides?
Sorry, Joanne, I just unshared it to try to stop the chimes.
Oh, thanks. Okay, well, what time are we at? Should we wait like 3 more minutes for everybody to come on in? How many people do we have? Let's see. 64 out of what? 164? I don't know. Hi, my name is Joanne Jarvie. Thanks for coming to my download, a monthly webinar diving into the intersection of healthcare and technology. I think we're going to give it like 2 more minutes so that other people can join us. And if not, they can always get the recording. Let's see here. I'm going to look at the chats. Thank you so much for being here. This is a big one for us. This is a big topic. Kendra, are you feeling ready?
Yeah, I'm ready whenever.
Okay, I think we're going to start. What time is it? Well, maybe 2 more minutes, 2 more minutes. Oliver, I see you. Thank you for being here.
Absolutely. I wouldn't miss it.
That's the right answer. Hi, everyone. Thanks for coming. It's the download. If you didn't come earlier, you missed our Muzak. I added a music portion. It was amazing. But then we turned it off, and then we had a lot of doorbells, and then we turned that off. So now we're here. April 27th, the download. Let's do it. Next slide, please. Hi, I'm Joanne Jarvie. I am the Senior Director of Outreach and Market Communications. I am MiHIN's big mouth. I am MiHIN's connector. I'm your host for today. I am constantly seeking clarity. I'm seeking connection. I want to continually remind our stakeholders why MiHIN is here to support you and to be listening. And I just appreciate you coming and being with us today. I hope you'll continue to come. I hope you'll give me more topics to dive into and to challenge people on. I hope you'll invite your partners and your colleagues, and we'll start, really spreading the good word of health information exchange. Next slide, please. MiHIN. What's MiHIN? MiHIN is a nonprofit organization. We provide technology and services to connect disparate sectors, our stakeholders, to securely share health information, to advance care, to create better outcomes, to lower costs. We do this as an unbiased data trustee. We move the data, and we supply technology and data really as a tool. And the tool and the services are meant to support humans. It's meant to make humans better. And the data is meant to provide meaningful information to connect, communicate, and collaborate, and to solve for health in our state. I'm about the people, right? There's technological infrastructure, and we have 200 people working at MiHIN, and most of them are smarter than me, and most of them work within the technical infrastructure. I'm all about the human infrastructure, folks. Technical infrastructure and human infrastructure. We'll see today how important they are to work together. Next slide, please. That was my welcome. Welcome. Today you are here. Interoperability. Like, what is it? Why is it important? How do we get there? What is there? We have Kendra Baker from the Interoperability Institute with us today. I asked her to prepare a presentation that people could feel comfortable then giving to other people. right? I'm really trying to get to the heart of matters, large matters in the downloads to break down complex topics into ways that we can understand and care about, and then follow those downloads up by an engagement called the Bits and Bytes, which is really the services, products, and technologies that MiHIN uses to solve for these larger topics. I'm trying to figure out for our speaker today, Kendra, who we have in the room. Rachel, can we try our poll? If you wouldn't mind taking a poll, because we used to do this on WebEx, but now we moved to Zoom and it's supposed to be easier to do polls. Okay. What stakeholder group are you representing today? Please take a minute to submit so that Kendra and our speakers can make sure to look at interoperability from your point of view so we can see who's in the room. How many people are in the room? 81. That's like half of the that's half of the registrations, right, Kate? It's okay. Do I have to submit? How do we see the answers to the poll, Rachel?
We have 55 out of 80 right now, so I'll just give it a couple more seconds for everyone to place their poll.
Thanks. That's Rachel. Rachel's my business partner. Rachel just held a 200-person engagement yesterday. Everything went off perfectly. It was pretty crazy how good she did it. Thank you, Rachel.
Of course. I'll give it 10 more seconds and then we will close the poll.
You can always, throughout any of my engagements, please interrupt, please challenge, please feel comfortable to come off camera and talk to us, to be here with us. Use the chat for sure. We've got people monitoring the chat. We've got people taking notes. We've got this recorded. It's all going somewhere. We're trying to make it better. So what did we find out? Who's in the room? Okay, hospitals and health systems lead, followed by physicians, organizations, health plans, prepaid. Oh, can you wait? I got to scroll. Let's see. Oh, others. Who are lots of technology suppliers, lots of others. Other. Oh, a fire develop wannabe. Oh my God, Kelly, have I got an organization for you? All right. Thank you for filling this out and thank you for being here. Let's not waste more time. Kendra, you are up. Tell us about this term. Actually, I'm just going to give one more thing. I want to say one more thing before Kendra goes. I came to MiHIN from a community-based organization that provided wraparound services for vulnerable populations. And we were looking for 4 years. I basically said, all right, look, why can't you just take in and we're just going to go to MiHIN and they're going to make it interoperable. We're going to take this referral platform and all we have to do is make it interoperable with the state innovation model. And that's it. That we'll be good to go. Look, doing that is not easy. Interoperability is not just integration. And there are many reasons why it's going to take a long time. It's a journey. And let's start learning about it. Kendra Baker. I think, Rachel, we're going to be going through Kendra's slides for her so she can talk to us.
Yep, absolutely. Just give me one moment.
I think it's on that same, it should be on the same thing.
Oh, is it?
It should be on the same slides. I combined them all together.
Oh, wonderful. All right.
There we go. So Kendra, you know how I do. Like I'm gonna put myself on mute, but if I don't understand something, or if I see something, or I hear murmurings, I'm gonna interrupt you. Thank you so much for being here.
Yeah, no, of course. Thank you for having me. So before we get started, I'd like to explain what Interoperability Institute is for any folks who aren't sure. The Interoperability Institute fits in with MiHIN's family of companies, and we're kind of the technical development and innovation aspect of this organization. So we're also a nonprofit, and we work towards finding healthcare solutions to improve patient care and push forward the reality of interoperability. And IOI does that through the development squads that we have, our workforce program for internships, and our sandbox environments, IOL and MELD. Next slide, please. So today we're going to go through a couple of things with interoperability. Before we really get into what interoperability is, I'm going to give you some examples of how healthcare works and how the interoperability is going to be able to change that. We'll get into what interoperability is and the different types of interoperability, and then some of the goals, benefits, standards that are around interoperability. Next slide. And I apologize, I'm probably going to say interoperability about 10,000 times. So, as I said, before we get started with the concept of interoperability, we have to be able to understand how the healthcare ecosystem works and why interoperability is needed. So let's start somewhere simple and think about the various factors that play into a normal healthcare encounter. And as I'm kind of going through my examples, I'd love for anyone to put their examples in the chat of different things that they see in the healthcare ecosystem, maybe from personal perspective or professional perspective. So on the screen, I have some very simple examples of things we see in healthcare. So for example, there's always going to be a patient in a healthcare encounter. There's always going to be a practitioner or a caregiver who is working at a location, whether it's a clinic or a hospital, where their encounter is going to occur. Most people are generally going to have some form of insurance coverage to help pay for their encounter. And generally, the practitioner is going to take some basic vital signs before performing any kind of procedures on their patient. And if needed, a patient may walk away from an appointment with their encounter with their practitioner with a prescription for a medication or a referral to see a specialist. So these are just a few examples of what can happen. But again, like I said, if anyone has other ideas they think would be beneficial, throw them in the chat. We're always happy to see what everyone has to say. Next slide, please. Yeah, screenings. Yep, that would be a great example, Joanne. So can you do the first animation for me? So what I'm going to do is give an example scenario of a healthcare appointment so that we have something we can go back to later on as we start discussing what interoperability is and what might change if interoperability was at play. So in this scenario, we have Kate, who's going to be our patient, and we'll see Dr. Smith, who's Kate's doctor. So Kate has decided to schedule an appointment with Dr. Smith, who's her primary care physician, because she hasn't been feeling very well. She's been experiencing headaches, dizziness, fatigue, and some other minor symptoms. So if you want to do the next animation. So Kate's going to meet with Dr. Smith, who's going to ask about Kate's symptoms. Can you do the next animation for me as well? Thank you. Yep. So Dr. Smith is going to ask about Kate's symptoms. She's going to ask how severe Kate's symptoms are, how long they've been occurring, and she's going to generally try to assess the situation. Dr. Smith is going to take Kate's vitals while assessing for any outward physical signs that could indicate what issues are occurring. Back one for me. Thank you. At the end of the visit with Kate, Dr. Smith isn't confident that she knows that she can accurately diagnose Kate without some outside help. So Dr. Smith decided to prescribe a general pain reliever to help with Kate's headaches and write a referral for Kate to go visit a specialist. She personally thinks Kate might need a CT scan or an MRI so someone can take a look. So she urges Kate to reach out and make a follow-up appointment as quickly as possible. After the appointment, Kate's going to end up needing to go to the pharmacy. She's going to need to get her prescription, and she's going to need to spend some time trying to find the right specialist to help her figure out what's going on. Next slide, please. So when we look at healthcare, not all appointments are easily wrapped up once the appointment's finished. In Kate's case, there were several things that need to occur after she left her doctor's office. Kate's medical records are going to need to be sent to whatever EHR her practitioner is using. Dr. Smith may also need to update their own personal records if they haven't done so already or they're outside of the EHR. And whatever payer Kate is covered by is going to need to catalog information about that appointment and determine what's covered and make sure that Kate has that information in her hands. And then at the end of all of this, Kate's going to need to do her homework and try and get her prescription and go find a specialist who can help her in the ways Dr. Smith wasn't able to. Next slide. So all of the activities that occurred before, during, and after Kate's appointment are going to need to be cataloged as data. In the world of healthcare currently, there's a lot of different data types, and each data type can be used in different ways to explain different aspects of healthcare. So let's look at a couple examples here that I have on the screen of some of the more common data types that exist. So we have ADT messages, which are admit, discharge, transfer messages. And these are used to convey the movement of a patient around a facility. So for example, an AO1 message is a patient admittance, and an AO3 message is a patient discharge. So ADTs are a message type that are helpful to healthcare today in our current ecosystem. So for example, if Kate, goes to her specialist and ends up in a hospital for any reason, there's going to be ADT messages that are generated to show her movement around that facility. ORU messages are observational result messages and are used to display clinical laboratory finding and imaging results for specific patients. So if Kate does end up getting that CT or MRI, we would see those results in an ORU message. CCDs are continuity of care documents that are built out following HL7's clinical document architecture standard. And these documents provide an overarching picture of what a patient's medical history looks like. CCD documents are longitudinal and they span long periods of time as they cover most or all of a patient's medical history. And then finally, we have X12 messages, which convey a certain amount of health insurance information, including things like eligibility benefits, claim status requests, and others. X12 messages are something that are going to be helpful to the future of healthcare. Next slide, please. So we've talked about this example, we've talked about some of the things that exist. So now let's talk about what interoperability is. And it's a broad topic. It's not something that solely exists in the world of healthcare. But if we do want to think about it in terms of healthcare, interoperability can be described as timely and secure access, integration, and use of electronic health data so that it can be used to improve health outcomes for individuals and populations. And if we want to try to boil this down to a very, very simplified explanation, interoperability is the act of having seamless, unified way to transfer healthcare data so as to improve healthcare for everyone. Healthcare interoperability isn't exactly a simple topic to understand. There are many moving parts, but if interoperability is achieved, then healthcare is not only improved for the patient, but for practitioners, payers, and other stakeholders. So, what might have changed with Kate's appointment if there had been true interoperability at play? And if anyone has any ideas, we'd love to hear them in chat. I can give you guys a couple examples that we thought of while you're thinking about what might have changed. And if you don't think of anything, that's okay. If you don't really know what interoperability is, we just, love to hear what you guys think. So if interoperability was achieved when Kate went to the doctor, there are several things that probably would have been different. For example, Kate's doctor would have stored all of her healthcare data in one data format in an EHR that could have been accessible by, whoever Kate's new specialist was. Kate's going to easily be able to consent to what doctors are able to see her healthcare data and how much data they can see it. And then that's going to be automatically tagged along with Kate. So any doctor who tries to reach out for that information is going to be able to see Kate's consent. It's also going to have been easier on the payers who would have been seamlessly integrated into the data transfer of Kate's coverage information and are easily able to access the relevant healthcare data that they need access to. Next slide, please. So as we've mentioned, interoperability is a broad and somewhat confusing topic. There are many moving parts that have to work together to achieve true interoperability. So one way that we can better understand how this is going to happen is by breaking interoperability down into the 4 groups that each focus on a unique aspect of the healthcare ecosystem. So if we look at the diagram on the right, we see our 4 types of interoperability: organizational, semantic, syntactic, and technical. And we're also able to see these arrows on the left and right sides of our diagram. On the left, we see the technical level associated with each aspect of interoperability. And on the right, we see if it's an automatic or if it's a manual aspect of interoperability. So for example, organizational interoperability, it basically runs itself. There's not a horribly large amount of work that needs to be done. Whereas technical interoperability, it requires quite a bit of work to make that happen. Next slide, please. So now, if we could go back one, thank you. So now I'd like to go into what organizational interoperability is. And this refers to the way in which public administrations align business processes to achieve mutually beneficial goals. Organizational interoperability is something that customers would be affected by, as these are front-end applications and tools and the standards that are in place. So when we look back at Kate and her medical encounter, there are several aspects of that encounter that could have benefited from organizational interoperability. For example, things like the program that Kate uses to authenticate that she is in fact herself when she needs to access her healthcare data. That same authentication program could be used all across the board. Or the programs that allow her doctor to instantly message her with test results after she's had her scans. Next slide, please. Now we're moving on to semantic interoperability. And semantic interoperability is the ability of computer systems to exchange data with shared meaning. In the use of semantic interoperability, users will generally see this through the transfer of their healthcare data from one platform to another. For example, from an EHR to a patient-facing phone application. And a really, really good example of what semantic interoperability is can be seen through health information exchanges. HIEs are a great example of semantic interoperability, as it stores and exchanges healthcare data without losing the importance of the healthcare data's meaning.
Kendra, hi, it's me, Joanne. I'm so annoying. I need to go back to the organizational interoperability for a second.
Yeah.
So when you were talking about Kate and her experience, who needed, when we talk about organizational interoperability, who needed to agree? Like, what are the organizations, or I'm not quite sure how, like, who would be needing to interoperate at the organizational level?
I think that it would be multiple people that need to do that. So it's, in a way, I think it's healthcare all agreeing on they're agreeing on a process. So for authentication, for example, so it's healthcare agreeing that like OAuth 2 is the method they want to use. And then it's, the technical organizations coming together to make that happen and build out the applications and the processes so that that can happen. So it's really, in a way, it's everyone, I think, if that makes sense.
So the organizational interoperability, which one's the easiest?
I think that that's a matter of perspective, I suppose, because, for example, organizational interoperability, once it's built out, it basically runs itself. So in theory, we would think that would be the easiest, but it also has to be completely built out very well first so that it can run itself. So there's a lot of front end work. Whereas technical interoperability, it's manual, but it could be easier because you're running it the whole time. You don't have to build it out so thoroughly in the beginning, if that makes sense. So I almost would say that the easiest one comes from whatever aspect of healthcare you're coming from. If you're coming from, the government level aspect, or are you coming from being a developer who's writing healthcare applications, that's going to play a role in what is the easiest form of interoperability for you, if that makes sense.
Okay.
Great. Awesome. So we can go on to the next slide, which is syntactic interoperability. And syntactic interoperability allows two or more systems to communicate and exchange data. So within syntactic interoperability, the interfaces and programming languages of the software don't have to be the same. And this can be really easily explained if we look at any of HL7's many different standards, like HL7 v2 or FHIR, which is Fast Healthcare Interoperability Resources. These are different data types, but they are used to convey healthcare information between different systems. So even though the data is formatted differently, it still accurately conveys the information within it. Next slide, please. So finally, we have technical interoperability. And this is associated with the hardware and software components, systems and platforms that enable communication to take place. And it's often focused on the communication protocols and infrastructure that allow these protocols to operate. Technical interoperability isn't something that's going to generally be seen by the customer or application user. It's really something that's going to be focused mainly on the back end. It's something that the folks who are working on applications is going to see. And we would see technical interoperability in play when we look at systems like UDAP and how they're integrated into workflows of existing software. Next slide, please. So when we look at interoperability, we know that there's goals, there's things that we want to achieve through this interoperability. And I thought that one way that might make it a little easier to view it is to try and break it down by who's going to be most affected by this goal. So it's not to say that, if you see one in the patient column, it doesn't affect practitioners or payers and vice versa. But I think it's a little bit easier sometimes when we can focus on one person who would benefit from that goal. So if we look at it from the aspect of everyone, reduce medical errors and protect patient safety is a goal of interoperability that would truly benefit everyone. And then if we take a moment and we look at the patient side, we have ensuring that patients and families are part of the care team and reduce cost, variation, and duplicated care. These are things that patients would see benefits from if they were able to have interoperability. From a practitioner aspect, we would see ready and full access to records on patient health, healthcare, and progress. Identify and better manage patients' risks to achieve the best outcome possible. Improve staff productivity and caregiver satisfaction, and ensure continuous quality improvement in learning. Now, while these are in the practitioner column, again, every patient's going to benefit if their practitioner is able to easily access all their healthcare records, if their practitioner has a better and easier time diagnosing what's going on because of the access to information. So it's not just benefiting the practitioner, but they're probably the group that would benefit the most. And then we have payers. We would see facilitating compliance with relevant rules, regulations, and contractual mandates, linked to new data exchange partners, so technology, analytics, and social services, automation of data entry and reduce administrative burden, and streamline relevant administrative workflow, including billing and quality reporting. Again, we'd see these benefits, especially to a patient and especially to the practitioner. I'm sure we've all had that time where we've gone to the doctor and had issues with the insurance. So for those things to be able to go away due to interoperability would be very beneficial for everyone. Next slide, please. So here we have some very generalized steps to achieve interoperability. And I mean, we could probably spend hours upon hours upon hours thinking of all the ways that we as people could try to help make this happen in healthcare. So we've got a couple examples here that could be beneficial. So one could participate in industry groups and bodies to share their knowledge and be the drivers for the outcomes they want and need. They could also make use of collaborative architecture like HIEs to reduce incorrect diagnosis and decrease patient burden. They could use natural language processing or NLP and other technologies to make data collection and retrieval more convenient. They could integrate workflows with point of care images, or they could build robust architecture that focuses on value add and moves time-consuming activities like hardware ownership and maintenance to the cloud. Again, this is another spot where if anyone has anything that they feel is a step to achieve interoperability in any aspect, we'd love to hear it in the chat. Again, this is just a couple of quick examples. It's definitely not all encompassing of the roadmap to interoperability, but it could be a couple steps along the way. Next slide, please. So interoperability is something that will benefit all the people who are involved in healthcare. It's not limited directly to those involved, but even those who are involved from a distance. And there are likely more benefits to interoperability than we could ever easily explain or put on a slide. But we have a couple examples here of what would be beneficial if interoperability was achieved. First and foremost, probably the biggest, obviously, is improving quality of patient care and patient outcomes. And with that, we'd also see an increase in healthcare efficiency and reducing the cost of care. There would also be a mitigation of physician burnout. We would protect patient data security, and there would be a synchronization of healthcare data. So again, these are just a couple examples. There's probably more than we could even think of that exist, but there's a few. Next slide, please. So new and old healthcare standards and rules have helped pave the way for interoperability in healthcare. HIPAA, for example, is a well-known law that protects patient privacy. And this need for patient consent and privacy when it comes to healthcare data is one of the many reasons interoperability would be really beneficial. And HIPAA helped pave the way for interoperability long before I think any of us were striving to see it in healthcare. The HITECH Act encouraged the world of healthcare to move on to EHRs and truly begin virtually exchanging healthcare data. So this meant there was going to be a need for new software and applications and rules that could help to continue to protect patient privacy while reducing some of the burdens that existed with having paper records for healthcare data. And smart on fire applications are a somewhat newer revelation in healthcare, but they too help reduce the burden on patients and providers by allowing them easy access to electronic healthcare data. And without these forward-facing applications, it would be much more complicated when patients are trying to access their healthcare data. So there are many other standards and rules that have come into play that have pushed forward interoperability. And these were just a couple examples. Next slide, please. So there are many different applications that exist out there in the world that we can use to help us understand interoperability more and how it might change the world of healthcare. And some of these applications, we're lucky and they're open source and they're free to use, so we can provide a unique benefit to us because we're able to access them whenever we want. So a couple examples of some different software that I thought might be helpful for people to understand is, the first one is PatientGen. And PatientGen is a synthetic data modeling tool that can be used to create synthetic patients that can be used for healthcare application testing and development. This is something that we at IOI use, and we populate our sandboxes with synthetic patients that can be mostly realistic and clinically relevant, so we can help people test their healthcare applications. ClinFire is a healthcare scenario builder to help people understand how various HL7 fire resources are used and fit together in a larger scale. It's something I like because I think ClinFire is what I like to call a little bit business friendly. You don't have to be a developer to use it and build out scenarios. You can build out anything you'd like and see how fire resources fit together and how much different healthcare would be if we were focused on one main data language. And then Meld is a healthcare sandbox that can be used with smart on fire applications to show how fire data will convey when it's used with real world applications. Again, this is an open source sandbox that also has synthetic patients in it, so there's no risk of PHI or having any issues. You can just go in and play around with it and see what happens. Next slide, please. So now that we've talked about interoperability, we kind of have a better idea of what it is and some different ways that people can maybe go and look and see what's out there. I think it's important that we focus on what IOI has done to push interoperability forward. I mean, we do call ourselves the Interoperability Institute. So we've established the Interoperability Land and Meld sandboxes, both of which utilize synthetic fire data to provide a way for developers to test healthcare applications and make sure that their healthcare applications apply to new and emerging rules and standards that are coming out. We participate regularly in HL7 Connect-a-thons with the various accelerator groups like Da Vinci, Karen, and Gravity to help provide them with resources so that they can test out new use cases and implementation guides and find ways to make them better. We've established a strong workforce program to help teach the next generation of healthcare workers, something I can personally vouch for. I was a member of the workforce program as an intern before I came on full-time at Interoperability Institute. We've established academic partnership programs to help university health IT programs learn more about interoperability, fire, and technology. And we've worked to establish the Interop community, which is a community that's focused around how we can make interoperability a reality through open source solutions and partnering up and breaking down barriers. Next slide, please. Joanne, I think that's what I got.
Oh, I'm muted. Thanks, Kendra. So we at MiHIN are on this relentless pursuit of interoperability. And I guess what I was hoping that we could discuss today with our healthcare partners, 21% in the audience, or the technology suppliers, or even the payers. Can you think of entities or organizations where interoperability would be problematic? In other words, sometimes I think to myself, who wouldn't want interoperability, right? What are the risks? We've gone over rewards. We've gone over potential benefits. I know that there is a lot of work that needs to happen. But does anybody here, feel strongly about what it might look like on the other side? Like, why'd you come here today? What do you think about interoperability? Do you think it's just a buzzword? Do you see it changing your business? Do you see it changing your patients? Michelle Lockwood, tell me something. Tell me about, right, how do entities without internet access or people who are not digitally connected benefit from interoperability? Does it only exist? Are the benefits only digital? Kelly Rice thinks it's a game changer. Kelly, tell me more. Why? Why is it a game changer? Why should we be working so hard for it? No, it's tough. It's tough to speak up. Who will we have? Should I start calling on people? Because I feel like I see you in this. I see you, my friends.
This is Julie. I'll be sure to I'll be glad.
Julie, you are my best friend, officially. You show up for me every time. Talk to me about interoperability.
Sure. So there are some difficulties with interoperability, as we all know. System to system will continue to have those interoperability issues, but there's also interoperability issues with things as simple as workflows, or even some of the, I don't want to really call them exceptions because that's a really poor word to use in interoperability. So I'm going to give you an example of it instead of using that word. I just can't think of a good word for it. There are times when there is not an information blocking, but an information delay. In times where for the patient's safety, maybe there's a lab result that's not released in a certain time frame because of patient harm that could happen. So there's sometimes those delays that occur. And those delays can really be an interoperability stickler sometimes when you're trying to care for that patient. So maybe provider A can get access to those things, but there's going to be a delay for provider B. And what does that mean for the patient? Especially if Dr. A is not doing his job. So.
Right. So it assumes that people are doing right. It assumes that, like in a perfect world, right? Yep. It's a noble goal. And it assumes that people are doing what they're supposed to be doing in the times that they're supposed to be doing it.
Yep.
Right.
But we all know they're human.
Only human.
I know.
Only human. I mean, for now. Look, Steve Grolke says in the chat, and feel free to use the chat. I love using the chat because it's like, people can't see you. You don't have to talk. But potentially people who don't want their health information shared because of privacy concerns. So when we were talking about that organizational level interoperability, those discussions and those policies around privacy and around stopgaps and guidelines and guardrails and who should have what information and for how long and for what purposes. So it's like, to me, but I said this before, but to me, that's the hardest work. I mean, we can make computers do, whatever we want them to do, but not everybody wants information shared. I mean, there's going to be people and entities that don't want to share. And I think, so convenings and getting out education, I don't think we have in the download today many. I've been wanting to do like a download for just people that go to the doctor. When I'm talking to my dad about interoperability and he's like, I don't think people know how their information is shared. I don't think they know how protected at this point their private health information is when we've been giving away our data to go online or to sign up for an app or to exchange like money into bank accounts, right? When I looked up to see what sectors are interoperable, the financial sector comes up a lot. Are you in your jobs in your everyday, and feel free to use the chat, how many times during a day do you think about interoperability? Does it come into your life? 90% for Julie Lowry. That's why she's my friend. But what about clinicians every damn day? Right, but should everybody be thinking about it? Should everybody be demanding it? Yes. All right. So our jobs, the bigger, wait, I'm seeing stuff. Downside, breach, right. The bigger the pool, right. The vulnerability. We were talking to our head of security yesterday, Lisa Mraz, and she was talking about, her job at MiHIN. It's quite a big job, right? And so you have the data flowing, and then if there's a leak, the whole thing leaks. What else can we tell you? So look, I'm going to set this up because it's my job. Rachel, next slide, please. Because this was a setup. You guys were set up by Joanne B. Jarvie. On Wednesday, May 11th, at Bits and Bytes, we're going to dive in deeper to how the Interoperability Institute is working to enable advanced interoperability testing and development through these digital platform test beds, these free fire lockers. There's all of this development stuff happening. And IOI is working through all the test beds. So what are you, if you guys are working on your interoperability, who are you working on it with? Do you need help? Do you need synthetic data? Do you need new people working on it? We have this workforce. They tend to work for us because we love them, but we're trying to build up the health IT workforce so that, people, the next generation will be like, how did you even do this without interoperability? How could you have even built it without it? John Newman, each transmission between software can generate new encryption challenges. Developers prefer to expand the capability of existing software, right? Where they can control the security more easily. Of course, that's a better business model. So do the consumers demand? Do consumers demand interoperability? Do patients start saying, this has got to follow me and I want this to go to this person, but this not to go to this person? I saw a Forbes article that said that you're going to be able to buy a car with your healthcare data. And I was like, oh my God, that's crazy. I don't know how I feel about that. Bits and Bytes. let's talk about Interoperability Institute. Let's talk about how it's there to support you, our partners, around this very deep work. And I guess the last thing I'll say, unless anybody wants to engage and challenge and be here with me, is that MiHIN is on a relentless pursuit of interoperability. And the organizational interoperability aspects, the discussions that need to happen, the rooms of people that make decisions. I feel like we're constantly trying to bring those people together and to have those conversations, to set up the use cases, to make sure that the policies are in place, to make sure that we're looking at it from privacy and security standards. This is hard but noble work. And we think about it all the time. And we use the word interoperability all the time. And I think that if more people start using it, I think we're going to have to start getting, I'd like to know what they're talking about. Like, are we talking about organizational interoperability here? Are we talking about semantic? Syntactic? What was the one after semantic, Kendra?
Syntactic.
Syntactic.
It's kind of a hard word. Yeah, I don't think
That's the one with fire.
Yes. Yep.
Yes. Okay. Are we talking syntactic? If you want to talk syntactic interoperability, please don't call me. But you can call up Interoperability Institute for sure. Does anybody have any more questions? Anything that they want to say, things that they didn't learn, or any more ideas that we can generate? This is your time. If you want it back, please take it. I so appreciate you having you coming here, and I'd love to see you at May 11th, Bits and Bytes. Any other thoughts for the good of the group? Stephanie Miller, why would you use an HIE versus an HIN for your data? Tell me more, Stephanie, knowing that you work for MiHIN. What are you thinking? A link to Bits and Bytes.
Sorry, I'm
I think
trying
you
to
have
find
register for the link. Hold on. Stephanie, what are you thinking? Where are you going?
I'm just wondering why some of our community partners in Michigan are sending their data to an HIE and not an HIN. I'm just curious, I really don't know what the differences would be.
Are you talking about how many different partners are involved in the health information exchange ecosystem?
Well, I mean, there are different HIEs, say, for example, Patient Ping, or, there are large national ones. There are some that are just in the state of Michigan. I'm just curious as to why some organizations would send their data there, who always have to send on to the HIN eventually, and some would do an HIN directly. I'm just curious.
Okay, this is Julian. I can speak to that from Henry Ford. So they actually send it to multiple, and some of the organizations within the HIE send it to multiple as well. But some of the reasons are because of the services that the HIEs are offering. So the HIN seems to handle use cases like, I'm going to send data to the state, or whatever purpose that might be. Med reconciliation, choose one, right? There's lots of them. But some of the HIEs are providing other services. For example, care management. And let me go into that a little bit further to explain to you the difference. Because I know that we're looking at creating, or we have the ability now to create ID numbers for the care managers to become part of the ACRES and all that now. But this goes beyond that. This takes into some of the consideration of the data that exists in skilled nursing facilities, for example. Some of the things that really we would love to get into the MiHIN level, me personally, I should say, not Henry Ford. And that is, how many beds do you have available today? What insurance does your organization take? Because every organization can only take so many Medicare patients, so many Medicaid patients, because that's just how their payer mix is. So how do they play with that? And they offer services like, hey, we're going to give you a portal for your patients to go in and choose, for their loved one, what skilled nursing facility their payer is going to pay for. So like, that's just an example.
That's very helpful.
So I think that's really just one of the many different reasons. The MiHIN is great. We share data. It is that hub and spoke that makes things so much easier. And there's a lot of work and a lot of data flowing through there. A gold mine. I loved that picture from last time at the MOAC with the little guy gold mining. Yeah, there's a lot of other use cases that I don't think one single entity can take, because it's such a rapid growing technology that there's so much happening.
Well, thank you, Julie. That's really informative, because when I think of services, I was thinking kind of more along the lines of data aggregation. So you've opened my mind to a lot of the other services that are available. Thank you.
Sure.
Have any other questions, suggestions, concerns? If not, we have 8 minutes. We have our bits and bytes. I tried to put the thing in the chat, but then I think the Zoom didn't work. But then my marketing partner, my marketing team said that we'll definitely be sending out the bits and bytes email. And I'm happy, please, to take your feedback, your suggestions for topics. We are here. I am here specifically for you. So use me. Thank you for coming. We'll see you next time.